I would like to welcome all our esteemed panelists who are cutting edge faculty of cardiology, and they are cardiologists from all over the country. First of all, I would like to welcome the teacher of teachers, Professor Muhammad Ishaq, who is a professor of cardiology at KIHD and visiting cardiologist at Tabba Heart Institute and Aga Khan University of Hospital. Next in the row is mentor of all young interventional cardiologists and pioneer of transradial interventionist, and he's Dr. Syed Hassan Nadeem Hassan Rizvi. He is director of cardiovascular and chief of cardiology department of at OMI, and he remained the director of satellites at NICVD, director cath lab at NICVD, and he is immediate past president at Pakistan Society of Interventional Cardiology. Next, we have Professor Mansoor Ahmed, who is consultant cardiologist and working in Medicare Cardiac and General Hospital, Ziauddin Hospital, and Hill Park General Hospital. I would like to welcome sir. Next, we have from Lahore Professor Zubair Akram. He is President PSIC and Director Cath Labs at National Hospital and Postgraduate Medical Institute. He is former HOD of Cardiology Department at Jinnah Hospital, and he is director. He was director at Cath Lab of PIC. He is also serving as advisor to DRAP, Punjab Health Commission, and Department of Health Department in Government of Punjab. Next panelist is Professor Javed Akbar Syal, who is immediate past president of Pakistan Cardiac Society. He is professor of cardiology at NICVD, and also he is working as executive director in SICVD. And last but not the least, most favorite cardiologist and the most famous one is Professor Fawad Farooq. He is professor of cardiology at NICVD, and he is secretary general Pakistan Cardiac Society. And welcome all the panelists. Today's topic of talk is practical approach of non-ST elevation ACS in light of current guidelines. And today's presenter is Dr. Umair Abrar. He is young interventional cardiologist and is working in OMI hospital. He has done his FCPS and in cardiology and interventional cardiology training from NICVD. He is also working as director cath lab at OMI network. Over to you, Dr. Umair Abrar.
Thank you, Dr. Iftikhar, for.
If anyone has any questions, kindly give those questions in question answers and chat, and we will give you the time, and we will keep the question answer sessions after this session. You have 30 minutes for the presentation, and after that we will have a question answer session and panelist expert opinion.
Thank you, Dr. Iftikhar, for the introduction, and I would like to thank Pakistan Cardiac Society for giving me this opportunity to present this practical approach of non-ST elevated MI in acute coronary syndrome in the view of latest guideline. And I am also thankful to the esteemed panelists who take out their time for this webinar. So let's start the presentation. So first of all, what we know is universal definition of myocardial infarction. So as per definition, it is a cardiac myocyte necrosis in a clinical setting consistent with acute myocardial ischemia. A combination of criteria is required to meet the diagnosis of AMI, namely the detection of increase and or decrease of cardiac biomarkers, preferably high sensitive cardiac troponin T or I, and at least one of the following criteria that's need to be made. Symptoms of myocardial ischemia: new ischemic ECG changes, development of pathological Q waves on ECG, imaging evidence of loss of viable myocardium, or new regional wall motion abnormality in pattern consistent with ischemic etiology. And in the last, intracoronary thrombus detected on angiogram or autopsy. So as per epidemiology, the proportion of patients with non-STEMI in MI survey increased from 1/3 since 1995 to more than half in 2015, mainly accounted for the refinement in the operational definition of non-STEMI. As opposed to STEMI, no significant changes are observed in the baseline characteristics of non-STEMI population with respect to age and smoking, but there are significant change observed in diabetes, hypertension, and obesity. So I will discuss this guideline according to the scenario. So this is the first scenario in which, there is a 55-year-old gentleman came in emergency department with complaint of chest pain for the past 2 hours. He doesn't have any comorbid condition. Vitally, he's stable. And in turn, accompanied with you in ER, ask about the guideline-directed approach for a patient comes to ER department with a chest pain. So what should be the approach? For the diagnosis of non-STEMI, you need to have proper history, proper examination, electrocardiogram, biomarkers of myocardial necrosis, and imaging. So history. So most patients present with a pressure type chest pain that typically occurs at rest or with minimal exertion lasting for less than 10 minutes. The pain most frequently started in the retrosternal area and can radiate to either or both arms, the neck, and the jaws. May also present with diaphoresis, dyspnea, nausea, abdominal pain, or syncope. In physical examination, it can be normal. You may find S3 heart sound, S4 heart sound due to myocardial ischemia, a paradoxical splitting of S2, a new murmur of mitral regurgitation due to papillary muscle dysfunction. However, these signs may also exist without non-STEMI ACS and thus are non-specific. So clinical assessment and initial evaluation for a patient with suspected ACS should be risk stratified based upon the likelihood of ACS and adverse outcome to decide on the need for hospitalization and assist in the selection of treatment option. This is class 1 indication. For the electrocardiogram, ECG should be done with for any patient who comes to the ER within 10 minutes of chest pain in ER presentation. Serial ECGs can be done after 15 to 30 minutes if the initial ECG is normal and there is a high clinical suspicion of non-STEMI ACS. In biomarkers, cardiac specific troponin like troponin T or I, when contemporary assays used, level should be measured at presentation and 3 to 6 hours after the symptom onset in all the patients who present with symptoms consistent with ACS to identify a rise or a falling pattern. This is class 1 indication again. Additional troponin level should be obtained beyond 6 hours after the symptom onset in patient with normal troponin on serial examination when electrocardiographic changes or clinical presentation conferred an intermediate or high index of suspicion. So if the symptoms onset is ambiguous, the time of presentation should be considered the time of onset for assessing the troponin levels. It is class 1 indication. And what is class 3? No benefit. With contemporary troponin assay available, CKMB and myoglobins are not useful for the diagnosis of ACS. So what's new? So this was a guideline published, though we all know the ACC guideline was published in 2014, and after that, no guideline has come from ACC. So the new guidelines are coming from Europe, and this is the guideline which published in 2020, European guideline for non-STEMI. The new recommendation for these guideline is as alternative to the ESC 0R to 1R algorithm. It is recommended to use the ESC 0 to 2R algorithm with blood sampling at 0R and 2R if an high sensitive troponin test with validated 0 and 2R algorithm is available. So you can use this algorithm for the rapid diagnosis and increase the accuracy for the diagnosis. So you can see there is an algorithm for suspected non-STEMI. So if you do a high sensitive troponin at 0 hours and 1 hour and you found it very low or low, so you can easily rule out the patient and you can discharge the patient or can admit the patient in ward for further backup. When the high sensitive troponin high or the 1 hour difference is high, so you need to rule in the patient. You need to admit the patient into CCU or ward. In between two, there is a other category in which you need to observe the patient and you need to send third set of troponin and do echocardiography and do according to the results. So this is the chart that's showing the value of low very low, and high sensitive troponin. And these are different according to the different machine. Like Roche, you can see very low troponin is 5 nanogram per liter, and low is 14 nanogram per liter. And the difference is normal or not significant if it's less than 1. And it is high when there is a troponin level of 52 nanogram per liter, and the difference of two sets is more than 10 nanogram. So what are the indications for imaging? In patient presenting with cardiac arrest or hemodynamically instability of presumed cardiac origin, echocardiogram is recommended and should be performed by trained physician immediately following a 12-lead ECG. In patient with no recurrence of chest pain, normal ECG finding, and normal level of cardiac troponin, preferably high sensitive, but still with a suspected ACS, a non-invasive stress test, preferably with imaging for inducible ischemia or CCTA, is recommended before deciding on an invasive approach. So echocardiogram is recommended to evaluate the regional and the global wall function and to rule in and rule out the differential diagnosis as class 1 indication. CCTA, CT angiogram is recommended as an alternate to invasive angiogram to exclude ACL when there is low to intermediate likelihood of coronary artery disease and when the cardiac troponin and ECG are normal or inconclusive. So for the prognosis, early risk stratification is required. Risk score should be used to assess prognosis in patient with non-STEMI ACS. It's class 1 indication, and this stratification model can be useful in the management as well. So the two known risk stratification system, number one, the GRACE score and the TIMI risk score. In GRACE score, you can have 8 variables and you calculate all the numbers. If it's more than 140, it's high risk, and if it's less than 108, it's low risk. And if in between these two values, it's intermediate.
फ्रेंच फ्राइज लाया यार, ये क्या ले आया? फ्रेंच फ्राइज ले आया.
So in TIMI, the other well-known score is TIMI risk score, and it tells you the 14 days in hospital mortality or recurrent ischemia. So it has 7 variables. Each variable is given one number, like age more than 65, more than 3 or 3 risk factors with coronary artery disease, and coronary artery stenosis more than 50%, with SC segment deviation in ECG, more than 2 anginal episode in prior 24 hour, and use of prior aspirin in 7 days, an elevated cardiac marker. If the score is like 4, so you can have risk of 14 days mortality around 19.9. If it's 6 to 7 and it is 40%, so it's high risk. So according to the now coming to the second clinical scenario, there is a 55-year-old lady admitted in ward with complaining of retrosternal chest pain off and on for the past 3 days. She's diabetic and hypertensive since 5 years. Her examination is unremarkable with blood pressure of 130/90 and pulse is 98 beat per minute with a regular, which is regular, and saturation is 99% at room air. Her ECG shows 1 mmHg depression in inferior lead while the echocardiogram is normal. Her high sensitive troponin level are markedly elevated. So what would be the strategy? Junior resident on duty, seek your assistance to initiate standard medical therapy for this patient. So how will you start? So our patient has saturation of 99%. So does she need oxygen? No. Supplementary oxygen should be administered to the patient when the arterial oxygen saturation is less than 90%, or patient is in respiratory distress or other high-risk feature on a hypoxia are present. So what are the recommendation for the nitrates? If the patient with the non-STEMI having chest pain, you can give 3 doses every 5 minutes for 0.3 to 0.4 mg sublingual nitrate. If the pain not settled, reassess the patient for IV nitroglycerin. Is a class 1 indication. Intravenous nitroglycerin is indicated for the patient with non-STEMI for the treatment of persistent ischemia, heart failure, or hypertension. Nitrate should be administered to the patient, should not be administered to the patient with non-STEMI who recently received a phosphodiesterase inhibitor, especially when within 24 hours of sildenafil and vardenafil and within 48 hours of tadalafil. For the analgesia, in the absence of contraindication, it may be reasonable to administer morphine sulfate in IV to the patient with non-STEMI ACS if there is a continuous ischemic chest pain despite treatment with maximally tolerated anti-ischemic medication, and it is class 2B, not 1 or 2A. So NSAIDs are class 3 indication, they increase the mass. For the beta blockers, oral beta blocker therapy should be initiated within the first 24 hours in patients who do not have any of the following, like patient do not have any signs of heart failure, evidence of low cardiac output state, increased risk of cardiogenic shock, and other contraindication to the beta blocker like PR interval prolongation for more than 0.24 second or third degree heart block without cardiac pacemaker. Patient can have active asthma or reactive airway disease. In this scenario, it is contraindicated. In the patient with concomitant non-STEMI ACL, stabilized heart failure, and reduced ejection fraction, it is recommended to continue beta blocker therapy with one of the 3 drugs proven to reduce the mortality in patient with heart failure. These are sustained releasing metoprolol succinate, carvedilol, and bisoprolol. Patient with documented contraindication to the beta blocker in the first 24 hours should be re-evaluated to determine their suitability for eligibility. It is reasonable to continue beta blocker in the patient with normal LV function with non-STEMI patient. It is class 2A indication. Administration of beta blocker intravenously is potentially harmful in patient with non-STEMI who have risk factor for shock. What about the recommendation for calcium channel blocker? In the patient with non-STEMI ACS, continuing or frequently recurring ischemia, and a contraindication to the beta blocker, a non-dihydropyridine calcium channel blocker like verapamil or diltiazem should be given as an initial therapy in the absence of clinical significant LV dysfunction that you need to rule out. An increased risk of cardiogenic shock if PR prolongation is greater than 0.24 second, or patient might be in second degree or third degree AV block without a permanent pacemaker, it is contraindicated. Oral non-dihydropyridine calcium channel antagonists are recommended in the patient with non-STEMI who have recurrent ischemia in the absence of contraindication after appropriate use of beta blocker and the nitrate. Calcium channel blocker are recommended for the ischemic symptom with beta blocker are not successfully are contraindicated or cause unacceptable side effect. Long-acting calcium channel blocker and nitrate are recommended in patient with coronary artery spasm. It is class 1 indication. Immediate releasing nifedipine should not be administered to the patient with non-STEMI ACS in the absence of beta blocker therapy and its class 3 indication. Short acting should not be used. So for the RAS system blocker, angiotensin converting enzyme inhibitor, ACE inhibitor should be started and continued indefinitely in the patient who have low ejection fraction of less than 40 or 40%, and they have hypertension, diabetes, or stable kidney disease, unless contraindicated. So ACE inhibitor should be used. ARBs are recommended in the patient with heart failure MI with EF less than 40% who are ACE inhibitor intolerant. So there you can use ARBs. Aldosterone blockade is recommended in post-MI patient who are without significant renal dysfunction like creatinine more than 2.5 in men and more than 2 in female, or patient have hyperkalemia who are receiving therapeutic dose of ACE inhibitor and beta blocker and have LV function of less than 40%, and patient might be diabetic or in heart failure. So here you can use aldosterone receptor blocker. Angiotensin converting blockade are reasonable in other patients with cardiac or vascular disease who are ACE inhibitor intolerant. It's class 2A indication. ACE inhibitor may be reasonable in all other patients with cardiac or other vascular disease. So recommendation for the cholesterol are high sensitive statin therapy should be initiated or continued in all patients with non-STEMI ACS and no contraindication to its use. It is class 1 again. It is reasonable to obtain a fasting lipid profile in patients with non-STEMI ACL, preferably within 24 hours of presentation. So, regarding the guideline for anti-thrombotic therapy, non-enteric-coated chewable aspirin of dose 162 to 325 milligrams should be given to all the patient with non-STEMI ACS without contraindication as soon as possible after presentation. And a maintenance dose of aspirin 81 milligram to 325 milligram per day should be continued indefinitely. In patients with non-STEMI who are unable to take aspirin because of hypersensitivity or major gastrointestinal intolerance, a loading dose of clopidogrel followed by a daily maintenance dose should be administered. A P2Y2 inhibitor, either clopidogrel or ticagrelor, in addition to the aspirin, should be administered for up to 12 months to all the patients with non-STEMI ACS without contraindication who are treated with either early invasive or ischemia-guided strategies. So option includes for the 12 months, you can give clopidogrel for loading dose is 300 or 600 milligram, and then maintenance dose 75 milligram daily. For the ticagrelor, it is 180 milligram loading dose, and then 90 milligram twice daily. It is reasonable to use ticagrelor in preference to clopidogrel for P2Y2 inhibitor treatment in patient with non-STEMI who undergo early invasive ischemic strategy. This is the trial, plateau trial, that shows the benefit. In the clinical scenario 3, there is a 67-year-old male, known diabetic and hypertensive, presented in emergency department in unconscious state. He revived after defibrillation for pulseless ventricular tachycardia. Post-Ross, his blood pressure was 100 by 60 millimeter of mercury and pulse is 90 beats per minute. His ECG shows significant ST depression in inferior lead with markedly elevated high sensitive cardiac troponin. What is the best strategy for such patient? Either a conservative medical approach or immediate invasive strategy or ischemia guided therapy or delayed invasive strategy. Let's find out. In the second clinical scenario, there is a 40-year-old lady, known hypertensive, presented to emergency department with single episode of typical chest pain in the last 24 hours. Her vitals are normal. ECG show no significant ST changes with mildly elevated high sensitive troponin. What is the best strategy for such patient? Conservative, immediate invasive, ischemia guided, or delayed invasive? Let's find out. So these are the strategies factor that decide the strategy, either early invasive or ischemia guided strategy. So for patient with refractive angina, sinus symptoms of heart failure or new or worsening mitral regurgitation, hemodynamically instability, recurrent angina or ischemia at rest, or low level activity despite intensive medical therapy, or patient have sustained VT or VF, should go for the immediate invasive strategy. So our first patient, this patient needs immediate invasive strategy. So those who have TIMI score of 0 or 1 and the GRACE score of less than 9 and have low risk top negative female patient or clinician preference in the absence of high risk feature should go for the ischemia guided management. Rest of the patient, those have GRACE score of 140 and there is significant temporal change in the biomarker, new or presumed new ST segment depression, should go for early invasive strategy within 24 hours. For the patient who are diabetic and they have renal dysfunction, GFR is less than 60 milligram per liter per minute per body volume area, and reduced EF less than 40%, and patient have early post-infarction angina, and he has PCI or she has PCI in last 6 months or prior cabbage, GRACE score is 109 to 140 and TIMI is more than 2, can go for delayed invasive strategy. So how you go if once you made the diagnosis of non-STEMI and and you either opt ischemia guided strategy or early invasive strategy, how will you manage the antiplatelet and anticoagulation? If you opt ischemia guided strategy, aspirin is class 1 indication, P2Y2 inhibitor clopidogrel or ticagrelor is class 1 indication, and anticoagulation unfractionated heparin, enoxaparin, and fondaparin, all three are class 1 indication. If you opt early invasive strategy, The anticoagulant and anti-platelet therapy is like aspirin class 1 indication, P2Y2 inhibitor, clopidogrel or ticagrelor class 1 indication, and apart from three anticoagulant, bivalirudin is added as a class 1 indication. So if you are going for the PCI for a non-ST ACS patient, so how you manage the antiplatelet and anticoagulation therapy? Aspirin, again the class 1, P2Y2 inhibitor in addition to the aspirin, like clopidogrel, prasugrel, and ticagrelor, all are class 1 indication. Glycoprotein 2b3 inhibitor, if not treated with the bilirubin at the time of PCI and patient have high risk feature, not adequately pre-treated with the clopidogrel, it is class 1 indication. And patient have high risk feature adequately pre-treated with the clopidogrel, it is class 2 indication. And for anticoagulation, all are the same except the fundaparinox, as the sole anti-agent cannot be used. It can be used either with a bivalirudin or unfractionated heparin. Otherwise, there is risk of catheter thrombosis with the fundaparinox. So if the patient is going for the CABG, how you manage the antiplatelet and anticoagulation? So aspirin is class 1 indication. You can go with the aspirin for the CABG, but continue clopidogrel and ticagrelor 5 days before and prasugrel at least 7 days before elective CABG. And if for urgent CABG, clopidogrel and ticagrelor up to 24 hours before should be stopped. Discontinuation of eftilfabine and tirofiban at least 2 to 4 hours before the surgery, and abciximab at ideally more than 12 hours before the CABG. So late hospital or post-hospital care, aspirin should be given, P2Y2 inhibitor, clopidogrel and ticagrelor should be given for at least 12 months. And if patient had PCI, you can add prasugrel in place of clopidogrel or ticagrelor for 12 months. So those were the recommendation. As you all know that the guideline which comes from American College of Cardiology, came in back to 2014. Since then, there is no new updates or guideline. And in Europe, the guidelines are coming. The latest guideline, which published in 2020, according to that guideline, how will you manage the antiplatelet? So aspirin is again the class 1 indication. You need to give loading dose of 150 to 300. And here they add IV aspirin, like 75 milligram to 250 milligram IV loading dose and a maintenance dose of 75 to 100 milligram for the long-term treatment. For the P2Y2 inhibitor, this should be continued for 12 months if there is no contraindication to these drugs. So the options are prasugrel and P2Y2 inhibitor receptor or naive patient.
You have
5 more minutes. Okay. So again, the prasugrel, ticagrelor, and clopidogrel all should be given, but the prasugrel is class 1 indication. Class 2 indication in preference of all. So it is not recommended to administer routine pre-treatment with P12Y2 inhibitor in patient whom coronary anatomy is not known and an early invasive management is planned. So if a patient having going for early invasive PCI, it's better not to give any antiplatelet until the anatomy is known. So then the fifth clinical scenario, the patient is 67-year-old gentleman with the known diagnosis of non-STEMI. He is diabetic and CKD. Baseline creatinine is 1.8 and TIMI score is 4. Your junior resident keen to know what are the changes in the management will you do in old diabetic patient who is also known CKD. So for the diabetes, it is recommended to do HbA1c and testing for all the patient. Avoid hypoglycemia is class 1 indication. If the glucose level is more than 180, it should be treated with the management of medicine team. And a multifactorial approach should be used for the diabetic patient. And in the last, less stringent glucose control should be considered both in the acute phase and the follow-up in patient, especially more advanced cardiovascular disease and older age patient and long diabetic duration and more comorbidities. For the recommendation of CKD patient, it is recommended to apply the same diagnostic and therapeutic strategy in patient with CKD. Dose adjustment may be necessary for the patient with normal renal function. It is recommended to assess kidney function by EGFR in all the patients. Both are class 1 indication. And use of low or isosmolar contrast medium is recommended as class 1 indication. Pre and post hydration with the isotonic saline should be considered if the expected contrast volume is more than 100 ml in invasive strategy. It is class 2 indication and it's very important indication. CABG should be considered over PCI in patient with multiple coronary artery disease whose surgical risk profile is acceptable and life expectancy is more than 1 year. For the older patient, you don't need to do any changes. Follow the same as you are following in the young patients. So the sixth clinical scenario, 40-year-old female with 5-month history of gestation, admitted with typical chest pain for 5 months, 5 hours. Her ECG shows significant ST depression, inferior lead with markedly raised high sensitive cardiac troponin. She is in cardiogenic shock and pulse of 110 beats per minute. What should be the strategy for this lady? So for the patient with non-STEMI, you need to find out if the patient have high risk. High risk can be refractive angina or new or worsening heart failure, ischemic mitral regurgitation, hemodynamically instability, or patient at VT/VF should go for the coronary angiogram. Such ladies should go for the coronary angiogram and PCI. For the low risk patient, manage conservatively on medical therapy. So here are a few drugs which are contraindicated. We must know before starting any ischemic or medical therapy in such patient. Aldosterone receptor blocker is contraindicated. ACE inhibitor is contraindicated. NOACs are contraindicated as well, and as well statin are also contraindicated. So for the radiation, ionizing radiation for the coronary angiography and PCI is considerable an acceptable risk in pregnancy when procedure is otherwise indicated. Fetal radiation effects are unlikely to occur for the dose level below 50 millisieverts. So it's a quite high dose. Given that the fetal radiation dose associated with the coronary angiogram is expected to be less than 1 millisieverts, and the risk of radiation injury to the fetus is likely negligible in comparison with the natural incidence of congenital abnormalities. So you can see here, there is a fetal risk of radiation in coronary angiogram is 0.07 milligari. And for the PCI risk of radiation for a patient for the fetus is less than 1 milligari. So in the fifth clinical scenario, it is very interesting. 70-year-old lady recently had PCI to LAD with single DAS for the non-STEMI ACS. She has no known comorbid but had intracranial hemorrhage 4 years back, which she recovered completely. She's also been treated for the chronic atrial fibrillation with apixaban 5 mg BID. She's very concerned about her antiplatelet and NOACs regime because her past history of intracranial bleed. So this is a very interesting chart which was published in 2020 in ESC guideline. If a patient undergoing PCI non-STEMI, how will you manage? So the default strategy will be triple therapy for the first week, and for the rest of the time till 12 months, it will be dual therapy, one NOACs and single antiplatelet. Best is clopidogrel, and 12 months only NOACs. But if you need to see a patient is high bleeding risk, so in this case, triple therapy is recommended for 1 week and dual therapy till 6 months, not 1 year, and NOACs after 6 months. For if patient have high ischemic risk, triple therapy should be continued for 1 month, and thereafter till 1 year, dual therapy is indicated with NOACs and single antiplatelet, especially clopidogrel, and thereafter 12 month NOACs is recommended. So these are high.
Umair, how many slides are left?
I
Because we are short of time.
Okay, I'm just finishing it. So, as I told you that American College of Cardiology published their guideline in 2014. Since then, no updates been came. So in 2020, ESC guideline published for the non-STEMI, and these are the some endorsement for the ESC guideline from American College of Cardiology. So these are the important points which I wanted to discuss with you. The following are the key points to remember from the 2020 European Society of Cardiology guideline for the management of acute coronary syndrome in patient presenting without persistent ST elevation. So a high sensitive troponin cardiac marker assay is recommended. High sensitive, you need to do high sensitive troponin and follow the 0 to 1 hour high sensitive algorithm to rule in or rule out for the patient. This is not in the ACC guideline. Routine pre-treatment with P2Y2 inhibitor is no longer recommended in patients with non-STEMI ACS with unknown coronary anatomy and planned early invasive strategy. It is class 3 indication, so you need to remember this. A central theme of this guideline is the assessment of bleeding and ischemic risk patient with undefined coronary anatomy and a plan for early invasive strategy, management should not receive pre-treatment with P2Y2 inhibitor because of the potential delay of care and increased bleeding of cardiac surgery is required, if cardiac surgery is required. In patients who proceed for the percutaneous intervention, prasugrel is the preferred P2Y2 inhibitor over the ticagrelor. There is a trial which compare ISR React 5 that shows the benefit of prasugrel over ticagrelor. The recommendation for the use of prasugrel over ticagrelor and delayed P2Y2 inhibitor administration is potentially practice changing. And while the safety of the delayed pre-treatment has been identified in both the registries and the randomized clinical trial, prasugrel is highly potent and should be avoided in patient age more than 75 and those with a history of cerebrovascular accident. In patient with atrial fibrillation and non-STEMI ACS taking oral anticoagulation, triple anti-thrombotic therapy with aspirin, clopidogrel, and direct oral anticoagulation should be administered for at least 1 week, which I told you earlier, with the de-escalation to dual antiplatelet anti-thrombotic therapy with clopidogrel and DOAX should be started. It's class 1 indication. The ESC guideline emphasized the need of individualized ischemic risk assessment during therapy selection. The recommendation for patients with AFib and non-STEMI strive to balance the risk of bleeding with triple antithrombotic therapy versus the risk of stent thrombosis with the dual antithrombotic therapy. A comprehensive risk prediction model incorporated both bleeding and ischemic risk factors should have a standardized decision-making for both the short-term and the long-term antithrombotic therapy. So thank you, everyone. You can see here the picture. A lady is performing a stress test, but not on the treadmill. The lady have a baby in his lap, along with the two sons pulling his trouser, and the two doctors which are performing his test, and they wanted to make the stress test as realistic as possible. So thank you so much.
Thank you very much, Umair. Very comprehensive presentation on non-ST elevation ACS. I know that 40 minutes or 30 minutes are very meager for this huge presentation, but excellently presented all the aspects of the presentation, especially covering every aspect along with clinical scenario. So we have some of the questions for the panelists. First of all, I would like to ask Professor Nadeem Rizvi if he is over here.
Yeah, thank you very much. Can you hear me?
Yes, sir. What are your thoughts about revascularization strategy, especially in patients with cardiogenic shock or those with heart failure in Pakistani setup? Because we know that these guidelines are.
Hello, I didn't get the last part of your question. Sorry, I'll just make a quick comment. I think one thing that is surprising to me is this fact that you should not preload, because this is not what is happening in practice. In practice, when a patient with non-ST comes in with, we don't really, we sort of take a clinical point of view. Any ST depression, chest pain, you send the troponin comes back as high. And I think, I don't know about NICBD at the moment and other tertiary hospitals, but we tend to load them initially because most of these patients, when they consent to having a invasive procedure, then we load them and take them up. I think there was this consensus about treating non-STs as STs elevation, and this risk stratification according to TIMI score and GRACE registry. TIMI score is still static, but GRACE registry is a registry. And my last point of view is, what my point of view is, that I think we should take everyone who is going to have invasive strategy, unless there's totally stable and a borderline troponin, and we should just load them. And if they are consented, why not just take them straight away? What's the harm? Is there any harm in doing an early invasive in everyone with a troponin?
Yeah, there is a Abrar trial in which they compare the patient with the immediate invasive strategy and delayed invasive strategy. They found there was no significant benefit for all the patient to take for the immediate invasive strategy.
Yes, there are
No,
certain
but there's no harm. I mean, you are delaying it.
Yeah.
You are just delaying it. Nah.
Yeah, actually,
Is there any
now
harm by doing it? Hospital cost, the patient's mental cost of going home. If you're going to either leave medically, then that's fine. If you initially stratify them and say this is conservative management, medical treatment is as good, then fine. But if you're going to delay it, then why? Why? What's the harm in
actually,
Nadeem,
newer ESC guidelines have divided this into immediate invasive and inpatient invasive. And they have labeled immediate invasive to those who are in cardiogenic shock, in pulmonary edema, mechanical complication. Immediate invasive means just like primary PCI. You have to take them from the ER to the cath lab. And these are the characteristics, 4, 5, if they are there. Otherwise, you have to take if they are intermediate or high risk. This immediate invasive is for very high risk. So for high risk and intermediate risk, it's inpatient invasive. And inpatient invasive, it means less than 24-hour or within hospital admission, you have to offer invasive strategy. In that sense, they have divided these two into two together. And regarding that preloading, it's not obligatory to not to preload, but routine preloading everyone, even if you are taking your patient to the cath lab within hour or within half an hour and preloading, that not justifiable. You will decide according to anatomy and see, because half an hour doesn't make much of a difference, but preloaded someone who needs urgent cabbage or that may harm the patient. So that's why they have now advocating, if you're taking immediately to the cath lab, it's good to preload the P2Y12 after seeing the anatomy.
It's
Next
not
question
now,
is
now, but I think it has been advocating from years and years. But what Professor Razi is saying, that whether we are sticking to this guidelines or not, then answer is no, because number one, because we don't have any concept of urgent surgery, and we haven't seen in our practice that patients are going for surgery, number one. Number two, usually these kind of patient where you can see that patient has a problem, as Fawad said, that directly patient was taken to the cath lab. Then what common sense says that only in those cases, there must be one culprit artery. So better to fix that one and then decide. So what we practically used to do, we always preload patient with this P2Y inhibitors.
I think that the point Nadeem was raising, that why not do intervention straight away on all patients since they all need it. I think the reason for NSTEMI is that during the middle of the night, as an emergency procedure, it always carry a little higher risk. Number two, in Europe, the reports from Europe has been lately that they have been under pressure with a long list, and they take their people are pushed very badly, and that is why they have prolonged the time. In fact, more recently, they've been recommending or suggesting that you can actually wait up to 4, 5, 6, or 7 days. And it's not because they don't need it or there is no urgency. It's just because there is a big pressure of workload. That's the main reason. That is why I think it is not recommended to take them straight away in the middle of the night if this is NSTEMI.
Dr. Zubair, one of the question is for you also, apart from this, keeping as an advisor to DRAP, this Prasugrel is not available in Pakistan, but to us, it is a very potent drug with OD dosing as compared to Ticagrelor, which is BD. Can we say that it would be better for Pakistani population to have Prasugrel, and would it be available in the future?
Bismillah, thank you very much. First of all, Umair, a very good presentation. So congratulations to you. So first of all, I'll respond to your question and then comment about this, what sort of antiplatelet should be given. Regarding Prasugrel, obviously it was available actually in Pakistani market about 8 to 10 years back, and it stayed there for about, I think, I don't remember the company, it was a local manufacturer, and then it disappeared, But there was some limitations to that. Obviously, body weight less than 60 or any history of stroke recent, and obviously age above 75. And as Umair has mentioned, it's one of the most potent, rather the most potent among all the three, whether it's clopidogrel or ticagrelor or prasugrel. So it was there, and that in those about 8 to 10 years back, and obviously maybe most of the cardiologists didn't go for it, and ultimately it was not a income generating product for the company, and it discontinued. But definitely it should be there. But obviously there has to be some criteria. It should not be given off 75. And regarding the previous topic which we were discussing, preloading of a non-ST segment elevation MI, all the three are not the same: clopidogrel, ticagrelor, or prasugrel. With obviously, if I have got all three available in my shelf, and without knowing the anatomy, I would never, for a non-ST segment elevation MI patient, I would never preload with the ticagrelor or prasugrel if it's available. I'll always, if I have to load it, I will load it with clopidogrel, because that has the least of the bleeding tendencies. So, but obviously with STEMI, obviously it's different. Obviously, loading with ticagrelor is better, or if prasugrel is there, it's better. So it's a debatable point whether you should load or not. But with my experience, obviously with clopidogrel, if you load, it doesn't matter. I would always load with clopidogrel.
There
with
is also
non-segment
a
elevation.
question from the audience regarding the dose of this clopidogrel. What's the initial dose as 300 or 600 pre-PCI loading?
So, with STEMI, obviously, with non-STEMI, obviously, it's 300 milligram. And obviously, with the STEMI, obviously, it has to be a 600 milligram. But obviously, depending upon the clot burden, when you see the anatomy, you can always build it up to 600 milligram, or you can add, because, it just depends upon the time when you have given the clopidogrel and when you have started with the invasive angiography or the invasive procedure. If the timeline is very small, then obviously you can just add with the 2B3 inhibitor also with 300 milligram of clopidogrel.
So continuing this antiplatelet talk, Dr. Fawad Farooq, if you would like to answer this, if be much rarity in Pakistan, but some of the patients who had left main or triple vessel disease on angiogram. So what is your practical strategy in antiplatelet therapy in those patients? Do you completely stop clopidogrel or what?
It all depends on how you are making a management plan for your patients. If you're taking them straight away to the cath lab, although it's indicated that not to give dual antiplatelet.
No. After cath lab, if the patient came out to be left main and triple vessel disease and is waiting for the
left
CABG.
main situation, because right now we are doing like 2 or 3 dozens of ACS daily. So even with left main, you have to decide, is the left main culprit in your patient or not? Most of the time, we see a lot of patients with left main disease, RCA infarct, circ infarct, mid-LAD infarct. And a number of time, we just balloon the lesion and then wait, depending on the anatomy, for the surgery. And during this period, patient is continue to have dual antiplatelet unless and until his surgery is decided. We very rarely have table-to-table surgery. So that issue
but
is
in that case, after TOBA, even if the patient is going for surgery, how many days do you skip?
It's all like for clopidogrel, it's 5 days, and for ticagrelor and prasugrel, it's 7 days. So you decide according to that.
I think now let me clarify
Yes,
this. You see, this presentation is a local. We are all local people here.
yes.
How many people are sending in tertiary hospitals like NICBD? We are not sending people. We had decided never to send anyone with ST or non-ST for surgery. And even now, unless it's a very special case, some VIP or something, I think the surgical results are very poor. So I think we should treat, we had decided, and usually this is the consensus when you talk offline with these people who make the guidelines. They say, if the STs and non-STs are essentially the same, it's just that it's an occlusive plaque versus a non-occlusive plaque. And you don't want to make that subocclusive plaque occlusive plaque and then make it a high-risk patient. So essentially, where there are facilities, I think Mansoor Ahmed is absolutely right in saying that the guidelines are made in Europe because of risk, because of prioritization with their finance and with their manpower. When you have enough manpower and everything else, I think in people like in NICVD, they should just treat STs and non-STs as the same, and no one should go for surgery, except certain groups where there is a complication or where there is a concomitant valvular disease or something. I think that's the practical message that we want to give across.
Yeah,
Locally, for local consumption.
we are doing that in a way that if your culprit vessel is left main or proximal left main, proximal LAD, if the culprit lesion is there, we usually do percutaneous intervention. There's no patient who's sent to surgery with this kind of anatomy. But I am discussing a different kind of patient where you have a small vessel disease which has done the damage. You have just taken care of that small vessel, and for rest of the anatomy, which is at stable state, we usually send them for surgery. Otherwise, with culprit left main, culprit proximal LAD, whatever we do it with percutaneous intervention, because leaving these patients even for a few more hours will be more dangerous as compared to intervening them. I agree completely.
We have a couple of questions from the audience also. First one is from Umar Hashmi. What is the guidance for troponin level checks in patients having heart failure or CKD? How high is high compared to the baseline troponin level for such patients? Anyone, Dr. Javed Syal or Umair, do you want to answer this?
We all know that there are different diseases or different conditions where troponin levels are high, and you have already described that heart failure, CKD. Definitely here, cornerstone is history, as Dr. Umair has clearly defined that how history behaves in these kind of cases. And history is, as a cornerstone, it's very important. So as far as cutoff value, I don't know myself, and I don't have read anything important for that cut value. But if you have a history which direct you that this patient has anastomia and there is a significant level of troponin high levels, then you should go for this management of anastomia. Otherwise, I don't know what are the cut levels of anastomia, troponin levels, anastomia in these two particular conditions.
Exactly, Dr. Javed Syal.
Umair has shared that slide,
yes,
because you have different kits of different companies and they have different reference ranges.
Reference ranges, exactly.
It is given there in that table that how much increase from the baseline if you are opting for 0 to 1 hour algorithm or
Exactly.
0 to 2 hour algorithm.
Exactly.
That will help you in deciding.
Context
With the for individual kits, whichever you is using for that. Usually it tries to thrice of the baseline. If it's static, most of the time it's CKD, heart failure, or other reasons of increased troponins, they are static.
Yeah,
the baseline will remain the same after 1 or 2 hours. But when you have concomitant non-ST or cardiac necrosis acutely, you may have difference in levels, and that is given in that table.
Fluctuation in the levels, yes.
Yeah.
Exactly. History is most important in this scenario.
Another question, sir, what do you think in 2024, every patient with non-STEMI who has raised troponins should undergo invasive strategy unless contraindicated? Dr. Nadeem Rizvi, what is your opinion?
Yeah, you see, we tend to follow these European and American guidelines, but we must adjust them according to. So in NICVD, it will be totally different. In OMI, in private hospitals, Aga Khan, Tabba, it depends on your local expertise, your comfort levels. You should not harm the patient. So if you've got manpower, why waste money? Why keep that patient? You already got so much manpower and equipment and everything else. Why keep him for 24 hours, 48 hours? So in certain institutions, if you are not harming the patient, then take him straight away. I would say that I would like in NICVD, for example, every non-ST, if there are equipment, inventory, everything is available, then all non-STs should be treated as STs. As soon as you find out it's, but in certain institutions where there are problem with finance, inventory, patient has to bring in money and all that, and if he can wait, then yes, 24 hours is fine. But then discharging the patient and risk stratifying him, I think that is where the debate has to be. Which patient with non-ST, where there is an increase in troponin, should be left on medical treatment without assessing the anatomy? Is there a group of patients who are low risk enough to be left alone conservatively? This is what my question will be. If they are not, then we are talking about invasive strategy in everyone. It's just the time that is different.
Next is
Nadeem, you're very right. Actually, Nadeem, you're very right. All of them need invasive strategy. Now, when we talk about, as you mentioning Europe and US and North American, they actually assess the cost effectiveness at one of their top priorities. So they follow those things. The patients can be followed. But yes, you are very right. Why keep a patient in a private hospital for 24 hours, 48 hours, or 3 days? Because it adds to the cost. So it's more cost effective in our part of the world to do intervention earlier than later. And I think that way, you're very right. We should consider that very seriously.
Keeping the same question in pace, what do you think, how long a patient should be admitted if he is low risk, chest pain free, and there is no evidence of high risk? How long should he be admitted in the hospital? Dr. Javed Sial or Dr. Fawad Farooq?
The question is that after procedure or once any patient?
No. If the patient is on conservative treatment and he is they are admitted for observation also, and he is low risk.
What the evidence says that, you know, that now these days, usually people discharge patient on same day as well. And what is our practice, as we are discussing what in NICD we do, we discharge patient after doing angioplasties in NSTEMI in 30 hours and less than 40 hours, sometimes 24 hours. And you yourself say that these are the low risk patients. Then after 24 hours, they can be discharged safely.
So in this, the guidelines are very clear. If you find a low-risk patient, do non-invasive testing like CCTA or thallium scan. Do these testing. If you find any high-risk feature, you need to take the patient to the cath lab. Otherwise, you can safely discharge if these tests found low risk.
My only question to the panelists and Umair is,
So
Javed, and this is important for you because you are director of
Dr. Naveed Roy, clopidogrel evidence. Yes, sir.
Sorry.
Yes,
Can I? Yeah. So my question is that in Pakistan, Umair, to you as well, that without conservative management, if you're talking about conservative management without an angiogram, and then there is conservative management after an angiogram. So in Pakistan, if we are saying that all non-STs, what I believe that ACS, whether it's unstable angina, non-ST or STs, in our world, it is much more cost effective to do an angio as soon as possible. And if there is relevant large area of supplying culprit supply, then you fix it and as soon as possible. So these guidelines don't really apply to us in such a way because, as Mansoor also said, and as I know, that it depends on the cost effectiveness, the logistics, the manpower. In our part of the world, especially in interior Sindh, it is not cost effective. The follow-ups are not there. The patient doesn't take dual antiplatelets, and then he's alone. So it's just the mechanism is slightly different. The severity is different, but all ACS are the same. You don't want an unstable angina to become an ST and then treat him within 90 minutes.
Very right.
So my contention will be that everyone should have an angiogram, and then you can do a conservative management if there's a diagonal block, or if there's an only diagonal disease, or if there's only PLV disease. So, but anything else, you fix it and then send them home as soon as possible.
So next question is regarding the dosing of clopidogrel. We have a very
Iftikhar.
Time.
Yes. Time 4 o'clock.
This
is the last
question. I was just add to Professor Nadeem Rizvi's comment is very right. I do agree with. Previously, we were also a bit conservative. If you think your symptoms are clear-cut, definite ACS, then irrespective of their intermediate, low or high risk, that patient should go for reviewing his coronary anatomy and then decide accordingly, leaving those intermediate risk or so-called low risk with typical symptoms is really very in a way that not cost effective. They will come with MI later on, or only those who are unclear in symptoms regarding ACS. These are the patient who need stress testing. Go ahead, Iftihar.
So can I ask the last question, if the time can? This is regarding the dosing of clopidogrel, especially post-PCI. Many cardiologists are using varied dosing regimen, like some of us are using 75 milligram OD, some of us are using 75 milligram BD dose. What is your experience regarding low dose or the higher dose? Like one of the questions from Dr. Naveen Roy also, that clopidogrel evidence from ACC, recent evidence is that high dose clopidogrel had lower incidence of 30 days MACE rates. So what should we follow and your experience regarding this dosing regimen? Anyone can answer, Professor Nadeem Rizvi or
I don't
Dr.
know
Mansoor.
about the rest of you, but for the last 5 years, I've always used clopidogrel twice a day for 1 month. Sorry, I've already butted in.
Yeah, I think.
Sorry, Javed. I've already told my point of view that for the last 5 years, I'm only using 75 BD in every patient for 1 month with an aspirin in addition. And after 1 month, we come down. The reason being that we overcome the resistance to certain group, which is
Professor Javed.
What we are 20% in our population, we had tested it. Sorry to interfere.
Okay. What we are doing in NICD, it's a by default that every patient who was discharged after primary PCR, elective PCR on clopidogrel 75 milligram BID. But usually sometimes they are given for 1 week, for 2 weeks, but that is a default strategy, unwritten direction for everyone. As you and Umair both worked as a post fellow in NICD, now you are also working here. So this is by default strategy in NICD. So we are following this strategy since we have started our practices.
Professor Mansoor, do you do differently or?
And as you say that now Naveen is also saying that this has changed slightly. There is low incidence of MACE within 30 days. So, you know, the science is always name of changing. So it's not that so after some time we might be using this BID for 1 year, because you don't know that what evidence comes with the time. But right now in our practice, even Fawad will agree that we used to give BD. Some consultant give for 1 week. Some consultant, like Professor Rizvi said, he used to give for 1 month.
Actually,
okay, I think let me give my input in it.
Right, sir.
I think we have.
Yeah. Go on, Fawad. I've finished.
Yes, sir. Previously, we used to do it I personally do it in very high risk complex anatomies, but nowadays, since we have ticagrelor available, so usually you can switch or upgrade your clopidogrel to ticagrelor in that situation if you think your patient is very high risk for thrombosis. So BD, just for sake of this resistance issue, I think since the availability of ticagrelor, we really don't need to give BD. We are now going to have a trial recently, TED Claude going on in NICVD that will answer this question.
Okay. Professor Mansoor, you have 15 seconds to give your opinion. If you do differently or the same.
So, okay, let me put my input actually. Can you hear me?
Yes, sir.
Okay. I think twice a day, I remember I started this twice a day habit many years ago. And it was basically because what I learned that some of the patients do not go on to treatment thinking that leaving it for a day or one dose does not matter. That is why I start them on twice a day. And when I see them after a week, then I give them a good time and explain to them how important the medicine is. Once they are aware that how important the medicine is, then I really cut it down to once a day, because there is some data that the dual antiplatelet does have somewhat higher risk for bleeding, particularly intracranial bleed and GI bleed. So that's why I think dual antiplatelet is cautioned for about a year, but doubling the dose, that was my logic to start with. And I think this was almost 20 years ago when they started doing that, or even earlier when Plavix was introduced. And at the same time, in those days, the stents we had were different stents. They were stainless steel, very thick. If can you imagine 150 to 180 microns, very thick, very hard. And over there, if you miss a dose, they used to clot straight away. And that was the reason why I started actually that practice. And I still do it for 1 week. Nadeem does it for 2 weeks, for a month. And many of us maintain that practice. And I think this is the safety. This is the safety net we should continue, because our patients are not very reliable on continuing medication regularly. So even if they miss a single dose, no harm is done.
Iftikhar, Dr. Suhail Aziz in the attendees are raising hand. If we can unmute him and take his opinion in that, if he's with us, just ask for that if possible. Otherwise, conclude the session.
Can you please unmute?
Can we see him?
Assalamu alaikum.
Yes.
Walaikum salam, sir.
Yes, Dr. Sohail.
Gee, how are you? It's such a wonderful symposium. I asked all my residents to listen in, and it is really very useful. And greetings to and salam to Nadeem Rizvi and Father Fawad and Syal Saab and everybody. And it's really nice to listen to this talk. There were just a few things which I thought were a bit thought-provoking. We normally look at an ECG and we say this pen has been having intermittent chest pain. There are non-ST elevation changes, some T inversion, some ST changes, and we kind of label them as non-ST elevation. And we then consider and think of non-ST elevation as a partial thickness infarct. So that we presume is probably a little less dangerous than the ST elevation infarct. But you find that many of the ST elevation, the non-STEMIs, have reduced ejection fraction. So I read a lot of articles, and it seems that many of the non-ST elevation MIs which we've labeled, which have reduced LV, are actually evolving ST elevation MIs, which we are seeing a little late. And now the elevation has settled down, and it's down to T inversion ST changes. So there's this very wonderful article I'd shared with you that you have to apply a door-to-balloon time of protocol, like Nadeem and everybody's been talking about earlier in this session, very rightly so, that there should be a door-to-balloon time criteria for non-ST elevation MI. All the trials have started showing that the earlier you do a revascularization is better. And of course, now we specify low risk, high risk. Now, I'm not going to get into that detail, but all non-ST elevation MIs should be done as early as possible. And they have to undergo a cath, because 30% will have a recurrence in the next few months, up to 3 months, and which may have a fatal outcome. So that is one aspect, that many of the non-ST elevation are actually full thickness MIs with reduced LVs, and they should be done as early as possible. And they compare a 24-hour cutoff period. Those who were done within 24 hours had a better outcome, and those who were done after 24 hours had a worse outcome. So that's something which I thought was really worth sharing. And I think there are two aspects to this lecture and this discussion. One is the academic part of it. And that is what needs to be done in the exam. And for the exam, we have to answer the way the stratification is done, and different aspects in the scores and all. But in real practice, if you look at our sort of setup, you think that patient had ST elevation, non-ST elevation MI, he had a low risk score, you do CT, well, you're actually doubling his cost, and how many CTs are there? So I still think that many of the data which we see are based on studies which are, 100% powered, and they have a low risk score. You do CT, well, you're actually doubling his cost, and how many CTs are there? So I still think that many of the data which we see are based on studies which are 100% powered, and they have a low risk score. You do CT, well, you're actually doubling his cost, and how many CTs are there? So I still think that many of the data which we see are based on studies which are 100% powered, and they have a low risk score. You do CT, well, you're actually doubling his cost, and how many CTs are there? So I still think that many of the data which we see are based on studies which are 100% powered, and they have a low risk score. You do CT, well, you're actually doubling his cost, and how many CTs are there? So I still think that many of the data which we see are based on studies which are 100% powered, and they have a low risk score. You do CT, well, you're actually doubling his cost, and how many CTs are there? So I still think that many of the data which we see are based on studies have been published and have shown benefit or not benefit. And they actually have been done, most of them have been done by non-invasive people. And they rely on these data, especially in the North Americas, for reimbursement purpose. That you did not follow protocol, there's a low risk case, you did the angiogram, we're not going to reimburse for it. So different aspects to it, and other things have been very educative, and my residents are giving me feedback also. They're thoroughly enjoying this lecture. And so those are my comments, and greetings to all of you once again, and thank you very much for asking my comments.
Thank you very much, sir, for your valuable comments and pearls of wisdom thoughts. I think we will end right now. Thank you very much, all the panelists and all the participants who have taken out their time during this month of Ramzan, during the fasting. And thank you, Dr. Umair, for wonderful presentation. Hope to see you in the next webinar, inshallah, in the next one. Thank you very much.